Medurstand. Understanding medicine.
Professor Azizur Rahman here. We are discussing the different modules on ECG, and we have covered quite a bit of curriculum defined earlier. And I think, yes, ventricular hypertrophy, we have done this much. And today we're going to take up this topic. Ectopics. Ectopics, you all know, are also called extrasystoles, and they could be of various types. They may arise from atria. We call them atrial premature contractions, APCs, or they could arise from junctional node, AV node. We call them JPCs, or I think most frequently they arise from ventricles. We call them ventricular premature beats. The different terminologies used, so I'm using APCs, JPCs, and VPCs. And if you prefer to use the other terminology, I don't mind, because we all refer to the same thing. Initially, I thought I will do separate videos for these three, but then I thought since the basic concept is same, and then I have to give you example to differentiate one from the other, so might as well cover all these three types of ectopics in one module. So this will be a little lengthy, but I think that will cover the entire concept of ectopics. First, let me introduce some terminology. Ectopic beats may be of two types. Ectopic means that something coming from outside SA node. So that would be ectopic. It may be premature beat, and the name says this beat is ectopic, but it comes before the next expected sinus beat. Then there could be escape beat. This is also an ectopic, but this comes once the next expected sinus beat does not come in its time. So this is in a way actually lifesaver. Then you can also classify them depending upon the site of region. They could arise from atria, they could arise from junction, AV node, or they could arise from ventricle. So accordingly, we call them atrial, junction, or ventricular. In one strip, you may have multiple types also. Then unifocal, multifocal. If you have multiple ectopics, they may all be coming from one focus, or they may be coming from different foci. And then sometimes there may be a wandering ectopic pacemaker. That means it is the same pacemaker, but it is not at one side, it is moving. All these things, they actually indicate underlying unstable myocardium and the conduction system, indicating that there is problem with the heart. It could be ischemic or some cardiomyopathy or some other problem. Sometime, in fact, many times, ectopics are just normal. Normal in the sense that you see them in normal people and they may not indicate anything serious. Then pattern, isolated mean just one off. Couplets mean two ectopic beats coming together. Triplets mean three ectopic beats coming together. Now, if there are more than three, then we call it tachycardia. So 1, 2, 3 may be classified as beats, but if you have more than three consecutive beats, then technically it is tachycardia. Ventricular tachycardia or junctional tachycardia or supraventricular tachycardia, depending upon the type of complex. Then aberrant conduction or blocked. Uh, Suppose there is an ectopic beat coming from the atria that is expected to conduct normally through AV node and rest of the conduction system. But sometimes it may not be conducted at all because AV node may be refractory. If atrial premature beat comes very early after the sinus beat, it might find AV node refractory and it may be completely blocked. So it might not show ventricular component of depolarization. Or it may be conducted as right bundle branch block pattern, sometimes left bundle branch block pattern. That means AV node has recovered, but one of the conduction branches, mostly right bundle, has not yet recovered from the refractoriness. So the atrial depolarization will pass on to the ventricles, but in a fashion of bundle branch block. So that is aberrant conduction. Then conduction, that ectopic current can move in various directions. Antigrade means it goes in the normal direction from atria to the ventricles, or in the ventricles from the AV node to downward. That is antigrade. Retrograde means that it goes backward. Normally, if you have an intact conduction system, intact structure of the heart, no anomalous pathways, any ventricular depolarization should not be able to penetrate atria. But in some cases they can. That would be called retrograde. That means goes backward. Concealed conduction is a very complex concept. That means depolarization enters AV node, but since AV node is refractory, the depolarization sort of dies there and never passes through. So this is concealed conduction. These are little difficult concepts. I have I have explained them very briefly, and if you are interested, you can of course read more about it or send me an email. I will be able to explain whatever you want to know more. This is our conduction system, a normal heart. A normal heart has got SA node, and that governs our heart because that has the fastest inherent rate that governs the heart. But there are many standby physiological pacemakers, and these are parts of our conduction system. Like, for example, there may be one here, an AV node. I think if the SA node fails, the second in command is AV node, or you could have some other potential ectopic rhythm pacemakers in the conduction system, usually in the atrium. But in the diseased heart, any kind of heart disease like ventricular hypertrophy, ischemic heart disease, cardiomyopathy, or some other toxic cardiomyopathy, any of these parts, any part of the conduction system, it is usually the part of a conduction system, not the normal myocardium. So any part of the conduction system may become autonomous, may become irritable, like this one is irritable. Any part of the conduction system may become irritable and starts discharging impulses. Now, normally these are kept quiet by SA node, but if there is too much irritability, then this might discharge maybe in the form of just one extra systole or two or three, or it might just lead on to tachycardia. So these concepts I'm going to explain in this video. What is the importance of ectopic beats? Usually asymptomatic or just the feeling of missing beat. Many people, otherwise healthy, young, no problem, no underlying heart disease, they just have this feeling as if the beat misses. That are actually ectopic beats. I think some normal things, excess of coffee or some other stimulant, cough syrups, ephedrine, or just normal mental excitation, sleeplessness, these can promote ectopic beats, and they may not carry any serious medical component. Frequency does not make them serious. If you have one ectopic beat per minute or you have 5 ectopic beats per minute, that perhaps is not important. But what is important is the underlying heart disease. What matters is the underlying heart disease. A normal healthy person with no myocardial disease, even 5 beats per minute, 5 extra beats per minute, maybe just little bit of nuisance, no problem. But if the disease, if there is underlying heart disease, then these ectopic beats could actually indicate the potential tachyarrhythmias and might require intervention. Most ectopic beats do not require any treatment other than a reassurance, but you need to be sure the underlying heart is normal. But they may trigger paroxysmal supraventricular tachycardia or ventricular tachycardia in predisposed individuals. Who are these predisposed individuals? These are people who have, because of their family history, they have some problem with their QT. QT is prolonged, and that provides more vulnerable phase where an ectopic can trigger a ventricular tachycardia if this happens in the ventricles, or paroxysmal supraventricular tachycardia if this ectopic activity is in the atria. I will briefly explain how this happened, but more detailed discussion on this concept will be covered in the next few modules, which will be on supraventricular and ventricular tachycardias. Now, this is the ECG, and let's examine it like we normally do. 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. But first, since we are discussing ectopics and ectopics relate to rhythm, so we must examine this one. So this is the rhythm step. You see, normally, like when we walk comfortably, leisurely, all steps are equal, right? This is normal thing. But when things get out of step, that is when we suspect there is maybe some ectopics. For example, I've just drawn your attention to this beat. This beat looks different than the other one. What are the differences? Number one, the morphology is the same. You see, this QRS complex, this QRS complex are similar. This is initial part upward, the second part downward, similar, very, very similar. Almost a ditto copy. And they are both narrow. Appears both are supraventricular. But what are the differences? This beat has come earlier than its expected time. And number two, the preceding P wave, if you compare this P wave with this P wave is different, implying that the origin of this supraventricular beat may be different than SA node. Now let's examine it little more. This is the normal beat, and this one is the next one. It was expected this time, and next one was expected somewhere here. So this beat has come earlier than its expected time. Okay, so you can call it premature. It is a premature beat because normal sinus beat was expected here. Now let me take this opportunity to explain again the difference between premature beat and ectopic beat. Since this is a beat which has come from a place other than SA node, but it has come earlier than the expected time, this is called premature beat. If the same had come somewhere here after where a normal beat is expected, then it would be called an escape beat. All right. So what is the diagnosis? It is an actually atrial premature beat. Why do I say premature? Because it has come earlier than the expected time. Why do I say it is atrial? Because its morphology, the ventricular depolarization is exactly the same as sinus beats. Because in atrial premature beat, it would be only the atrial depolarization which will be different as shown by the different morphology P wave. But once the current passes through the AV node, rest of the process depolarization, the passage of current through the conduction system, ventricular depolarization, AV nodal delay will be exactly the same. So this is how we call it atrial premature beat. Now let me give you the criteria for atrial premature beat. Uh, of course, basic rhythm is sinus. So a beat which is premature and narrow. Okay, so this is premature and narrow as the sinus beat. Now, why this asterisk? Because if somebody has pre-existing condition which is causing broadening of QRS complexes, like somebody having left bundle branch block or right bundle branch block pre-existing, in that person the sinus beat will be broad. So in that case, this ectopic will also be broad. So I should say actually the ectopic, the duration is the same as sinus beat, usually narrow. Morphology same as sinus beat. I already explained once beyond AV node, depolarization is the same. then the morphology of atrial premature beat QRS complex should be the same, preceded by an abnormal P and PR. This P is different because this P, the origin of this ectopic is not SN node, so it has taken a different course in the atria, different direction of atrial depolarization. So P wave would be different, and PR interval may also be different because it depends how far or how close that ectopic focus was from the SN node. Now you must also appreciate that if this ectopic focuses in the neighborhood of SA node, then P wave might just look similar to the SA node, the normal SA node. Then there is incomplete compensatory pause. And now this, what it means at the moment, please hold this and you just remember that this is one of the diagnostic feature. Once I do ventricular premature beats also, then I think it will be easy for me to explain what is meant by compensatory pause. Just to explain these concepts a bit further, I would like to show you this picture. I draw this picture. This is a theoretical picture, schematic diagram. This is the whole heart, and this is the insulator between atria and the ventricle. Only the AV node would allow the current. So this is the normal sinus node. Normally current arises from here, then go to the AV node, and then it depolarizes the ventricle. In case of ectopic, just assume that this is the ectopic focus. An ectopic current started from here before the next SA node activity was expected. This has depolarized atria in a different direction. The current is flowing this way. So that is why P wave morphology is different. And the distance of this ectopic and AV node may be different than the distance between normal SA node. So the PR interval may be different or may be the same. Then once beyond AV node, the current flows in exactly normal fashion. That is why the QRS complex is exactly the normal as we see in this particular patient, in this particular ECG, in SA node activity. I hope this was clear. Let's move on. Now this is another ECG showing the same. See, this is the normal. Maybe I should draw these arrows correspond to the atria, but I've drawn them QRS complex. So this is the normal beat. This is the normal beat. Another normal beat was expected here, but much before that we have an ectopic beat. See, this has come earlier than its expected time, so it is premature. It has got more or less the same complex, narrow, and slightly shorter than this, but it is more or less the same morphology, and it is preceded by a P wave which is different. So I think this is also an atrial premature beat. But what about these things? What do you say about this? I think any beginner, any person who does not understand this ECG fully would probably think that these are VPCs because VPCs are generally broader and generally of different morphology than APCs. But this could actually be what is called an APC with aberrant conduction. So suppose this was actually an atrial depolarization superimposed on the T wave. See, this is actually an atrial depolarization superimposed on previous T wave, and this was conducted through the AV node, but it found right bundle branch refractory. The left bundle was responsive, so the supraventricular ectopic beat was conducted in a fashion of right bundle branch block. So this is called APC, atrial premature beat with aberrant conduction. Aberrant conduction can take the pattern of right bundle branch block or left bundle branch block depending upon which bundle was refractory and which bundle was responsive. We know from our knowledge of physiology that right bundle has got longer refractoriness and can conduct lesser number of beats per minute. So it is more likely to be right bundle branch block as the case here. So this was like an APC which might look like a VPC. Let's take this example now. If you examine this from this side, this is the normal PQRS, normal PQRS, normal PQRS, normal PQRS. But what about this one? You don't see any P wave. There is no P wave, as if atrial depolarization did not occur. And then we have a QRS complex which is very similar to the normal. It is premature, it is not preceded a P wave, and it is not broad. It has got the same morphology. This is limb lead 5. So what do you see? What do you think it is? Is it atrial premature beat? Could very well be, but there is no P wave. Could it be ventricular premature beat? Not likely, because the QRS complex is not broad. It has got the same morphology as sinus beat. Very occasionally, if the ventricular focus is just distal to AV node, you could probably have this kind of morphology also. What is another possibility? No PEEVs, narrow QRS complex. Another possibility is junctional premature beat. So the ectopic focus was in the AV node. AV node is called junction. So it is a junctional premature beat. Okay. So in junctional premature beat, you could have a slight APC-like complex with a P wave that may precede QRS complex, or may be merged in QRS complex, or it may follow a QRS complex, depending upon where exactly in the AV node this ectopic focus is. If it is in the middle, it would be merged in the QRS complex. If it is in the upper part, it might be seen before QRS complex, but with a short PR interval. If it is in the distal part, it may be seen in the immediately after the QRS complex. So these are junctional premature beats. Now this picture will explain it further. You see, this is the ectopic focus. This one, blue, and current has arisen. It has gone backward as well as forward. So if this current goes at the same time, then this atrial depolarization will be merged into QRS complex. If it is before that, you will see a P wave just before the QRS complex, but this P wave will be inverted because this P wave is conducted this way. So it would be not like normal P wave, it would be an inverted P wave. And the QRS pattern would be just like normal SA node activities, because this conduction is normal. So thank you very much. This has been Professor Azizur Rahman. I'll see you in my next video, which will cover ventricular premature beats. I'm from Medurstand, which offers free videos on all topics on internal medicine, including ECG. I really look forward to see you in my next video. Please, if you like the videos, spread the word around and ask other people to join. Thank you very much.